just a really basic outline here of the female anatomy in the human. Here we have a stylized diagram of the uterus, demonstrating here the cervix, the ovary on the left and the right, the fallopian tube, the end of the fallopian tube here called the fimbria, which opens up like a flower, and then this particular area here it's lined by a particular type of gland type endometrial lining. This is another side profile of the female pelvis. This is put up to let you know basically the relationship of the uterus next to the bladder. As you can see, the bladder here in the cross section is really in front of the uterus, and behind the uterus, this structure here is called the rectum. And I will be discussing during this presentation when I'll be talking about cul-de-sac or the pouch of Douglas, and I would be referring to this particular area here. So the lining of the uterus is lined by this tissue called the endometrium, and this is a histological picture of what it looks like once you've stained it with a special what we call a H&E stain. So endometriosis is defined as the presence of ectopic endometrial tissue. So ectopic means tissue that should not belong to, it has come from a different area. In this case, it's a reason from the lining of the womb, and it's found in areas other than the uterus, so outside the uterus, in other words. The common sites that you would find endometriosis are in the uterus. When it's in the uterus, it is defined as adenomyosis. You can certainly find them on the ovaries, either just on the surface or within the ovary itself, where it becomes known as an endometrioma or a chocolate cyst. I will show you some pictures in a minute. It can be found in the pelvic side walls. Sometimes they can be found on or within the tubes, on the bladder, in the area called the cul-de-sac, which I have pointed out earlier, and definitely on the rectum, and sometimes invading the rectum and or the bladder. In rare instances, endometriosis may be found in areas outside the pelvis, such as the abdominal wall, in the diaphragm. It's also been reported in the research papers in far-flung places like the lungs and the brain, but these are extremely rare. Now, the other message to get across tonight or this evening is that endometriosis is really not a cancer. We are not dealing with a cancer. It affects women in the reproductive age group, so fairly young women and normally fairly healthy women otherwise. It is common. It is thought to affect up to 10% of the female population. Now, I think in some population group it may be much higher than that. For the patients that I would see, the infertile subpopulation group of women, I see up to 50% of these women with endometriosis. This is another picture diagram here of what endometriosis looks like. Schematically here, they look like superficial sort of blood patches, and on here this is a drawing of the endometriotic deposits. I must apologize for I think the picture has come across a little bit blurred, but I guess you could get a glimpse of what I'm talking about here. So these are little spots of endometriosis. The other thing it causes is this filmy adhesions, like a white band of scarring tissue. This diagram, a picture here serves to demonstrate what adenomyosis means. So these are gland-like structures actually within the muscle wall of the uterus. They look like tiny little holes, much like a sponge. If you squeeze the specimen of a uterus after a hysterectomy in a woman with adenomyosis, these little gaps here are often filled with blood. So they're like little sponges, just squeezing the blood from a sponge. I know I'm being a bit graphic here, but just for you to get an idea that how this can actually cause pain. This is a picture taken at the time of laparoscopy or keyhole surgery, showing a uterus that is quite thick. It is globular in shape. It's filled with adenomyosis. And you can also see on this picture actually superficial lesions of endometriosis actually on the surface of the uterus. This is the histology, meaning that when you slice through this uterus and plate it, and it's then stained with a special microscopic stain, you can actually see here the glandular or little holes that you typically see in a deposit of adenomyosis within the muscle wall of the uterus. This is another picture taken at laparoscopy where you can see slightly two different types of lesions. One is a more red, angry looking lesion on the side wall of the uterus. Just to orientate you a bit, this is the ovary, so you're focusing down, looking down into the pelvis and panning left across to the side wall of the pelvis, and you can see that this lesion there is a slightly older one which is scarred. Interestingly, you can see that these lesions have a fairly active blood supply. They're actually drawing blood from the surrounding vascular network to serve it, to let it grow. So it is an active lesion. This is a slightly more advanced picture, a picture of a more advanced endometriosis. And again, just to orientate you, you can see the uterus here at the front. You can see what we call the round ligament to the side here, and the rectum is at the back here. And this is the left pelvic side wall, so the bladder is at the front. And on the skin of the bladder, what we call the peritoneum, you can see these angry-looking blisters of endometriosis. Essentially, they're filled with altered old blood. This particular lesion here, just from looking at it, would suggest that it's probably slightly deeper. It may invade, a bit deeper than just the skin of the lining of the bladder. Now, this is another lesion known as, infiltrating endometriotic lesion, or DIE, deep infiltrating endometriotic lesion. So when you proceed to resect that lesion, you can see that that actually invades a fair distance into the tissue, causing pain. This is a picture of a cyst that was removed at laparoscopy, and when you cut into, it was removed at the laparotomy because the cyst is still intact, so it was cut into it, and you can see the content of the cysts spilling over out of the cyst, and it looks like chocolate, but in actual fact, what it is altered blood that looks a bit like chocolate. So let's talk about patients that are at risk of endometriosis. What are the risk factors? We know that endometriosis runs in family. We know that if your mother has endometriosis or has bad period pains that you might suspect that she had endometriosis, you are quite likely to have endometriosis. In fact, it confers a 6 times increased risk than the general population. Similarly, if your sisters or any first-degree relatives would have or are suspecting to have endometriosis, then you're at 6 times increased risk. If you have your period early, that seems to be a correlated risk factor as well. If you've not had children, that's also a risk factor. If you're born with a uterine or a womb abnormality resulting in a poor drainage of the womb, and a condition called, I've listed one, there are many of course, and this is only but one. It's called imperforate hymen. These patients have constantly would get backflow of blood into the pelvis, resulting in pain and also eventual development of endometriosis. Some of these women, it's been reported that about close to 100% of these women will eventually develop endometriosis. Thin women also are more likely to have endometriosis, and smokers as well. So what problems does endometriosis cause? I have alluded to before, it obviously could cause bad and painful periods, heavy blood flow, menstrual blood flow. You can sometimes get blood in your urine during the period. This is quite rare, and if you see that, it may suggest that you may have endometriosis within the bladder. Now, I don't mean that you see a bit of blood on the urine when you wipe yourself at the time of period, because most likely what that problem is that you just have blood and urine mixed in after you've been to the toilet to ease yourself to urinate. That's not what I'm talking about. I'm talking about blood actually coming mixed in with your urine, coming out of the urethra at the time when you pass urine. Now, that can be tested. If you suspect of that, you should see a doctor, and the doctor can actually test for it. Blood in the stool or in the feces, especially noted at the time of a period, and this is rare as well. And if you do have that, it may suggest that you have endometriosis in the rectum or the bowel. Pain when you have bowel movement at the time of the period. There is a medical term that is called dyschexia. When the doctor says that, that's what they're referring to. You really don't need to know it, but I just thought I'd explain it to you. The other, probably quite a common association with endometriosis is pain during sexual intercourse. It's called dyspareunia, and the pain is actually often felt deep inside the pelvis. It is not. I'm not referring to pain on the outside. I'm referring to pain on the inside. It may be associated with a certain position. Sometimes it is so bad that the couple may have to stop. So that's deep dyspareunia. And how does endometriosis cause infertility? Well, let's just quickly outline what infertility means. Strictly speaking, infertility means an inability to conceive with regular intercourse after about 12 months of trying. When I mean regular intercourse, I'm talking about 2 to 3 times a week. Now, the other issue is that when the doctor assesses you, the doctor may be able to detect a painful lump or nodule during examination. And I will mention a bit later on, pain is actually a major disincentive to have intercourse. When you have intercourse and it's painful, you would want to avoid it. So that's one of the reasons how some of these women with endometriosis may have infertility. They're just not having sex. Now, there are 3 other methods how endometriosis may cause infertility. Mechanical obstruction, having scarring around or actually inside the fallopian tubes. That may also cause, obviously will cause blockage of the tube. As you know, the fallopian tube is a conduit or a channel that carries the ovulated egg every month, and it gets swept into the fallopian tube. That's where the sperm meets the egg and fertilizes the egg. So if there is any problem there with the egg being transported or the sperm getting to the tube and fertilizing the egg, you're going to have an issue with infertility. Having endometriosis on the ovaries, around the ovaries, can actually damage the ovaries and decreases the egg quality. Now, we know that with patients with endometriosis donating eggs as a donor to other less fortunate women who are not producing eggs, we found that those women who donate eggs with endometriosis, their eggs generally have a lower fertilization rate, lower pregnancy rate, and lower live birth rate. So we know that they generally of a poorer quality as compared to someone without endometriosis. The mere presence of endometriosis within the pelvis causes a toxic environment. It makes the pelvis hostile. It would then interfere with the function of the sperm, the egg, and also the fertilized egg, the implanting embryo, may be affected in some ways. This is just a quick picture to point out to you what an inflamed fallopian tube might look like. And as you can see, it's inflamed like that. It doesn't look normal compared to that. The function of that tube is obviously not there compared to a healthy looking normal tube. This is a picture taken again at the time of laparoscopy, keyhole surgery, where you can see the ovary. Clearly you can see this sausage looking rather convoluted tube, which is clearly not healthy. It is in fact very sick. It is surrounded by all these filmy adhesions or scarring, and you can't really see in this picture the end of the tube, or what we call the fimbrial end. The fimbrial end in this case would not be normal, and the tube is basically, headed. So how do you diagnose endometriosis? Clinical history, the doctor will ask you questions, or the specialist, and in fact you can gain a lot of information from just talking to your patient. The doctor will then examine you, as I have alluded to earlier. During examination, the doctor will feel for tender spots, feel for nodules or little lumps vaginally. There are tests that the doctor may order. There is a blood test that some doctors order and is looking for a chemical marker called CA125. Now, it is a non-specific test, I must say. It is not that reliable, and it's not that discriminatory, meaning that if you have a raised CA125, it doesn't mean that you've got endometriosis. It may mean that you've got some other intra-abdominal disease. But having had endometriosis, you could use CA125 as a tracking marker just to see whether the disease has returned. You could use, well, the first line of imaging a doctor would organize, well, at least in my practice here in Australia, is I would do a high-level, high-quality ultrasound scan looking for, the presence of this so-called endometriomas or chocolate cysts. And sometimes you can actually visualize the nodules directly. You may be able to assess if endometriosis is present by the behavioral characteristic of tissues. For example, normal healthy bowels would slide among, on top of one another. In disease state, they often don't. So you can infer from that that there's probably lesion. But safe to say that most endometriosis cannot be seen on ultrasound scan. But it is a good screening first-line test. MRI or magnetic resonance imaging scan I would use this testing tool more as a mapping and to get an appreciation of the severity of the disease in a particular individual to help me plan for surgery. Now, laparoscopy, as I've mentioned before, keyhole surgery is actually one of the best ways to diagnose. Like I say, you can't often see it on scans. you really need to site it at laparoscopy, take pictures, and not only that, you need to remove the lesions. I treat all my endometriosis patients by resecting the lesion and then sending it to the lab, and the lab can actually see the lesion and diagnose it and confirm it. That's the only way really at this current state to visually diagnose and histologically confirm the presence of endometriosis. And at the same time, when you do that, you are removing the lesion and you're also treating the condition, which can help the patient with pain and ability to conceive. So just quickly touch on how you treat endometriosis. Well, treatment really depends on a number of things. It depends on your age. You know, if you're a younger person and, you know, single, not really desiring to start a family yet, the treatment may be very different to if you're an older patient or about to think about, you know, just recently got married and want to start a family. Your treatment would be a little bit more different. Signs and symptoms, you know, you may have minimal symptoms. I have seen patients with minimal symptoms and signs and symptoms, and they present to see me with infertility issues, and at the time of surgery she has a lot of endometriosis. The other situation is I see women with, you know, significant amount of pain. They go for a laparoscopy and you really don't find a lot of disease. You do find a little bit and you treat them and they get better. So the point I'm making here is severity of disease does not equate with you know, the degree of pain necessarily. If I see an endometrioma on ultrasound scan, I would do surgery with keyhole surgery. And sometimes you get, you know, parents, parental request, you know, wanting to investigate the child, you know, because mothers suffer from endometriosis. She knows how terrible it is, pain that she's experienced, you know, in her younger days, and also that she might even have experienced difficulty getting pregnant. Parents may sometimes insist that, you know, you investigate their daughter. Well, you don't always need to treat if, you know, I mean, if someone who's young, 16, you know, started her period a couple of years ago, she has bad pain, but not too bad, she's still, you know, coping reasonably well, I would in some instances, you know, investigate her, and sometimes I may not need to treat her, but if her symptoms are to the point where they often come to see me, I usually would start them on a pill, a contraceptive pill. Yes. Now, the contraceptive pill, you don't obviously only use it to prevent yourself from getting pregnant. Very commonly, gynecologists would use contraceptive pill to regulate one's cycles, to control one's volume of bleeding. And in endometriosis, it's actually quite a good first-line treatment to suppress the disease. However, if they then become refractory or they don't respond to a pill, then I usually would perform surgery. These two are the drugs that are listed here are not used as first line. They are used for women with recurrent disease or have very bad disease. And sometimes this particular one here, Cinerel, is actually used for women if you want to prolong their suppression of the disease prior to starting IVF. So this is just a quick demonstration, a picture here of what laparoscopy or keyhole surgery mean. Typically you make tiny little cuts ranging from about 5 millimeter to a centimeter in various configuration on the abdomen, and quite commonly you get a little cut in the belly button. A fine needle is inserted, usually through the belly button, and the carbon dioxide gas is then infused into the tummy, and that would then permit and allow the surgeon to insert the other instruments on the side safely to allow us to maneuver and manipulate internal structures and operate. It is certainly now the first choice, a first approach to most pelvic surgery now. It is less invasive and and you certainly recover much quicker. I just want to show you here a picture of a patient that I've resected the endometriosis. I'm not sure whether this comes across clear on your screen, but you can see that this is the uterus here. This is the round ligament coming off the sides. This patient does have a small little fibro, which is at this stage inconsequential. She has got this lining. It looks like a skin, and here you can see little craters created. Basically what I've done here is resected the skin and peeled it off, containing the endometriosis. So it's important that you completely resect it to minimize it from coming back. So the treatment of endometriosis, we know that by treating endometriosis, it actually helps to improve fertility. Some patients may not get pregnant after surgery. They may need, in fact, to move on to assisted reproductive treatments. I won't go into much more detail than just mention it in passing, but they may need IVF and IUI because I don't quite have the time to go into that tonight. So I guess the take-home message here is don't put up with pains, bad period pains, especially if you take painkillers and it doesn't get better. You're needing to take time off work. You're not coping. It's affecting your life. This is not normal. People might tell you, your relatives, friends might say, well, look, that's normal. I had it before. Well, it may not be normal. I think it is probably prudent to at least see your general practitioner or your primary care physician first, and then go from there. Because bad period pains may mean that you have endometriosis. Now, the other thing about endometriosis is that if it's unchecked, it can actually ruin your life. I've outlined the reason why it could, because it can cause infertility. This last little point I want to make here is that at this point, we're still not very good at picking it up because it still takes us 9 years before, on average, before endometriosis is diagnosed in most women. So it may take up to 4 to 5 years before the woman even present to see the doctor and realize that there might be a problem. And then in some instances, it may take another 4 or 5 years before the doctors realize that there is an issue and refer you on to a specialist. So we should aim to reduce this time lag from diagnosis, from presentation of symptom to diagnosis and treatment. So if you suffer bad period pains, just don't put up with it. Please see a gynecologist.